Well, there's been a lot of late news, exciting news with regard to atherosclerosis, PAD, and CAD. We have had some recent meetings, the European Society of Cardiology, as well as others, have really highlighted, I think, novel aspects of these disease states. We continue to advance in terms of our understanding of different ways to modify lipid-mediated risk. I think that's very exciting, going beyond just LDL to things like Lp(a) and other markers of risk, icosapent ethyl. We are also understanding the role of anti-inflammatory therapies, and there was novel information at the American College of Cardiology meeting around IL-6 inhibitor, and we know that there are data from CANTOS to support this access. We don't have available therapies yet, but these are important. And then finally, diabetes drugs. We know that there are more and more agents out there looking at effective therapies for MACE reduction, heart failure reduction. The SGLT2 story continues to unfold, more data for GLP-1s, and now novel mechanisms of action. And then the last thing I'll speak to is thrombotic risk, and especially in PAD, the recognition of heterogeneity in the disease states, and that there are patients that are really high risk of MACE, those with polyvascular disease. And then recent data from the VOYAGER-PAD trial showing those with lower extremity revascularization, very high limb risk. And now the dual pathway approach with factor Xa inhibition and aspirin has been approved in the post-revascularization setting. And I think for the first time, an agent approved to reduce limb adverse events like major vascular amputation and acute limb ischemia, really opening a whole new development pathway for therapeutic intervention in peripheral artery disease. Well, I think in 2022 in the CAD-PAD space, a few things that practitioners will be sort of embracing here or looking forward to. One is further personalization and characterization of patients. I think as more and more therapies stack up in our armamentarium and we have to make decisions about what to do next, we need to think about comorbidities and how we might stage those therapies. And so I think there's going to be more and more information about which approach for which patient. And we see a lot of that, particularly in the antithrombotic space, where there is a safety concern. And so who's at low bleeding risk, who's at high bleeding risk, and then amongst them, what is the right therapy for the right duration? So in some ways, the more data we get, the more complicated it gets. But we have dual antiplatelet therapy with aspirin and P2Y12 inhibition. We have P2Y12 monotherapy. We have aspirin and rivaroxaban. And so who's the right patient for what approach? I also think we'll be learning more about different targets in terms of LDL reductions. How safe can we go? And it seems like the data show there's no lower limit for safety for LDL reduction. And so that's a suitable target. Which patients should get icosapent ethyl? Which ones should get an SGLT2 or GLP-1? But I think risk stratification and approaches to personalized management will be on the horizon for 2022. I think for many medical practitioners that aren't doing vascular interventions, now the Voyager data have really put the post-revascularization PAD patient in a similar state as the acute coronary syndrome patient. And so these transitions of care from the acute to chronic and how we medically manage them to optimize their outcomes, that's on the horizon. And I believe that we're going to have more and more focus on therapies in specific populations where there have traditionally been health disparities. And how do we better treat those populations? How do we better enable them to get accurate diagnosis, early treatment, and even other populations such as those in rural settings where it's been harder to deliver care. And then the last thing in 2022 is I really think we're going to see the emergence of implementation science. And so how do we bridge the really elegant experiment to tell you whether drug A is better than drug B, and how do we bridge that to the clinic and understand how to deliver that in a better way? And I think there's much more momentum now around awareness and implementation so that we can do a better job of translating trials into the clinic. Yeah, I think there are a lot of novel therapies that are in the pipeline that are going to be really exciting as we think about the future of treating coronary artery disease and peripheral artery disease. I think the observations around modulating the thrombotic cascade inhibiting thrombin generation through factor 10A, along with an antiplatelet, both in coronary and peripheral artery disease, to open the door for a lot of therapeutic development. I think particularly as we think about novel endpoints like acute limb ischemia and amputation, we've never had drugs that could modify those outcomes. And I think we're appreciating how frequent and morbid those outcomes are. And so in the pipeline, not only will there be drugs like rivaroxaban, where we're learning more and more, but there are newer anticoagulants that move higher up the coagulation cascade, which really, as my colleague, Dr. Berkowitz says, hold the hope of decoupling ischemic risk reduction from bleeding risk. And so factor 11 inhibitors are in development now, and they really hold the hope of, when combined with an antiplatelet, can we reduce ischemic risk and play either no bleeding risk cost or less bleeding cost. And there've been already promising data from early phase trials. So factor 11 inhibition. I think there are novel metabolic drugs like those focused on Lp(a), and then drugs that we're already using and looking at different indications. So there are trials now looking at GLP-1 agonists in peripheral artery disease and function, and whether the benefits that are seen for MACE and cardiovascular mortality extend to other vascular endpoints. And so I think the pipeline is interesting, not only because of the mechanisms, as I mentioned earlier, IL-6 and inflammation, dual pathway approach with rivaroxaban factor 11, but also the outcomes. We're looking at a broader spectrum of outcomes and recognizing that these disease states are actually quite heterogeneous, and we have to study them independently. So a lot of interesting science on the horizon. Yeah, I think one takeaway for all of us that struggle in the clinic and are 15 minutes with each patient and try to do the best that we can. One thing we need to do is make the diagnosis, right? So for patients with peripheral artery disease, we know that they are widely underdiagnosed. Take people's socks off, feel for a pulse, order ankle brachial indices. For coronary disease, do the appropriate testing, diagnostic testing when it's warranted. And then we have to act, and we have to enable our patients to understand risk, have them understand or help them understand the role of their therapies along with lifestyle, and really do everything that we can to improve the provision of care. So now that we have more tools in our toolkit, let's identify the patients at risk, educate, and partner with patients to make sure that we can optimize outcomes.